Good morning, good afternoon, good evening, wherever you are. Welcome to this MDS roundtable, which is run by Blood Cancers Today. It's a true pleasure to be with you today. My name is Amer Zeidan. I'm an associate professor of medicine at Yale University. And today we will be covering a lot of the exciting developments in the field of MDS. The last couple of years have seen important approvals and some important changes to the risk stratification as well as the classification of MDS. And to debate all of these new aspects, I'm joined today by three of my colleagues. All of them are top experts in MDS. So Jamie, this issue of the different classification systems has certainly caused a lot of uproar in the community, and there is, I would say, largely negative feelings about having two different classification systems. So how have you been navigating this with your patients and in your collaborations with the pathologists at your institution?
So that's a great question. And I'm hoping that the community is really going to start to embrace this new classification system. I am certainly adopting it in my practice, although some of the clinical trials, obviously, that we're enrolling patients on are still using some of the more, traditional or should we say outdated classification systems. So our pathologists, we've had conversations. They are well aware of these new classifications. And I think for those of us who have been treating this disease for a long time, this is kind of intuitive. I think we've always understood that a patient with a TP53 mutation complex cytogenetics and 12% blasts, acts like AML rather than MDS. So I think, again, for those of us in the community who've spent a lot of time treating this disease, this is sort of intuitive, and we're happy to see the classification systems catching up with what we've always understood to be inherently true about this disease.
So do you do this also in your institution, Sangeetha? Does your pathologist report by both classification? In the reports, do they have the ICC and the WHO category?
Yes, that's correct. So if, say, as Jamie said, it's 10% blast, we call it as oligoblastic AML, and sometimes it's NPM1, MDS, and 10% blast, and it says as, okay, this is, again, this is a different classification for AML, but then the ICC, the WHO and ICC says that AML with NPM1 is, regardless of the blast percentage, it is AML. Similarly with MDS, sometimes what happens is, even with del(5q), when it is present with SF3B1 and del(5q), then it becomes an issue because both of these are separate classifications. So MDS with del(5q) is a defined entity, and then MDS with SF3B1 is a defined entity. So in that case, I don't know what to do, because most of the times what the pathologist says is, okay, according to ICC, this is what it is, and this is what is according to the WHO.
Yes, I think in my experience as well, it has been important to have good communication both with the pathologists as well as the patients. I was always struck by the fact that some patients, for example, are so focused on not having their MDS develop into AML. Yeah. This is like their top priority. Even when the blast count is 18 or 19%, they are so focused on not crossing the 20%. And I think it was very important to make sure that some of these artificial divisions between the diseases are not super emphasized to the patient. So I think having that MDS/AML category does have its own advantages.